Hello, I'm Dr. Omar Bey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. As usual, I'd like to talk about my favorite subject, and that's caring and sharing. Sharing our med moments, and you know what med moments are, those times when, something occurred that you knew you should have gone to the doctor a little sooner. I want those moments to be shared. Email me so we can help others. If they experience and they have some knowledge of your med moments, it may stimulate them to go see their doctor. Email me, www.medmoments.com. That's www.medmoments.com. We have a tremendous show for you today, and we have a great topic. The topic is going to be colorectal cancer, and I have an expert in surgical oncology. Interesting, I love medical words, surgical oncology. His name is Dr. Kevin Clark. He's a surgical oncologist. Welcome to our show, Dr. Clark.
Thank you for having me.
Oh, yes. Now, this is a very, very important topic because so many of us have cancer sometime in our lives. I was reading something the other day and it said 40% of people sometime in their lives may experience cancer of some type. Mm-hmm. Yeah. So it's such a widespread problem that I'm so glad you could come and talk to us about it today.
Thank you.
Let's start, and I always like to start very, very basic. You know, I'm a basic kind of guy. What is put it this way. Explain where the colon is first, and then we'll start talking about what it does and things like that.
All right. The colon essentially it's part of the gastrointestinal tract, and it's actually towards the end of the gastrointestinal tract. It basically the function of the colon is mainly to reabsorb water and for storage, for waste. The rectum is the very last end of the gastrointestinal tract. So it's really large intestine or colon, it's the last part of the gastrointestinal tract.
Okay, so let's step back just for a second.
Okay.
Gastrointestinal tract.
Okay.
Now, are you talking about, we're talking from the mouth to the rectum?
From the mouth to the bottom.
Could you go through and just let us know what stages going from the mouth, where we are going all the way down, and so we have some concept of where the colon is and what it does?
To start, we start with the mouth, then we go to the pharynx, which is the back part of the mouth, then to the esophagus, which is a long tube that connects the mouth essentially to the stomach.
Right.
Then from the stomach to the small intestine, and the small intestine is the largest part of the gastrointestinal tract. From the small intestine, now we get to the colon, and then to the rectum. So it's really towards the end of the gastrointestinal tract.
Okay. You said something else too. You said that one of its main jobs is to reabsorb water. Correct. Now, when you say reabsorb, that's a big word. I know. Kind of break that down for me.
So basically, it brings it back into the body. So what it does is it allows us to capture that water that's normally secreted or that's in the intestine, so that we don't become dehydrated.
Okay. All right. So what you're talking about is that we eat a lot of things,
right.
All pizzas and all that kind of good stuff, and it goes down through the system of the bowel,
right,
into the stomach and gets churned up, and then it goes into the small bowel and it gets absorbed. The food or nutrients or whatever we live on gets absorbed. And then it goes to the colon, and when it gets to the colon, there's a lot of fluid inside the colon.
Correct.
It comes out of the colon back into the body itself so that it actually forms stool.
Correct.
And that's what we evacuate as our stool. Interesting. They're very, very good. Now, as far as how does, I understand that we have all of this and we eat and it gets into the stomach, what we eat, but how does it move along? I mean, why doesn't it just drop in the stomach and stop?
Well, basically, it gets propelled or pushed along all along the entire intestinal tract. There are muscles that push it along. So it gets propelled forward basically by gravity, some of it's gravity, and also it gets pushed through.
All righty, all right. Now, are there times when, there are times when I know that some patients will complain of constipation. And you said that the normal part of the colon is to absorb that water. Sometimes does the colon absorb too much water? Is that why people get constipated, or what happens there?
Well, constipation really, it's a complicated topic. It can be related to functional issues, and when I say functional, meaning that sometimes the muscles in the colon don't work as well in some individuals.
Okay.
As far as the amount of water that's reabsorbed, that really is not a particular symptom that's associated with constipation.
Right.
And typically, when you say constipated, it could mean that somebody has 1 or 2 bowel movements, or they could have 5 bowel movements.
Right.
It's a very individual type of thing, but the definition that I would stick by, basically it's a patient who cannot have, or their normal bowel habits is affected. So if they normally had 2 or 3, and now they have 1, then that would be a situation where they're constipated.
Right. Now, the thing of it is that our focus here is colon and rectum cancer. Right. Explain cancer to me just very briefly so we know what we're talking about.
So cancer, it's an abnormal growth of cell tissue.
Okay.
Or tissue, essentially. So it's, in our body we have cells and tissues that are normally expanding and growing. But that's a regulated process, meaning that cells grow and then they die. They grow and then they die. With cancer, it just continues to grow. So the part where it's supposed to die is lost. So it just keeps growing uncontrolled. Okay. The hallmark really, it's not just growth, it's the ability for the cancer or the tissue, when it grows, to go to other parts of the body, and that's really what cancer is.
Okay, so you're saying that these cells that are continually growing, then they kind of hop on a motorcycle in the bloodstream and go other places.
Correct.
And they can continue to grow in other places too.
Right.
Now, that's called, I understand, metastasis, or it's metastasizing, or it's going to another location.
Correct.
All righty. Interesting. Now, in the colon, are there certain things that would make you more prone to cancer in the colon? For instance, constipation. Can that cause, like if I'm always constipated, am I likely to get cancer? Or, or if I eat red meat all the time, am I likely to get cancer? What's going to cause me to have cancer? Now, I want to know, because I don't want to do those things.
Right. Well, it's interesting. There are a lot of things. Everything causes cancer, and nothing causes cancer. It's a very, if you look at it.
You sound like a politician,
But the things that we do know, there's several things that we do know. So a low fiber diet is associated with cancer. Patients who have inflammatory bowel disease are at increased risk.
Okay. Just break that down, because we'll pass that and we don't understand what you're talking. Inflammatory means swelling, I'm assuming.
Swelling, and it's irritation of the bowel wall.
Okay.
There are conditions that patients have where there's constant irritation of the bowel wall, and that constant irritation can predispose you to developing cancer.
Okay.
The other things, and we'll probably get into a little bit more, is some patients have a natural tendency, or not really a natural tendency, but a genetic predisposition, which is based on their family history. Right. So they inherit certain predispositions from their parents, certain genes that put them at risk of developing colon and rectal cancer.
So if you said, if dad had colon cancer, then there's a good chance that his offsprings or his children may have colon cancer sometime in their lives.
Well, what we can say is that they're at increased risk.
Increased risk, okay.
With hereditary colon cancer, which is a separate group from sporadic. So if we break it down, most people who get cancer, it's sporadic cancer. Meaning that
it just happens for not no reason, but we're not sure why it happened to them and not someone else.
Correct.
Excellent.
Correct. As opposed to hereditary cancer, where we know it's passage of a particular gene that the parents had.
Right.
So, and that's the big difference. So with patients who have hereditary cancer, we can predict reliably the percentage or the chance of them getting cancer.
Right.
With sporadic cancer, it's much harder to predict that.
Interesting. All righty. Now, I know there are patients that either very thin patients or very fat. The size, change your chance as far as cancer is concerned, like colon cancer. Like, are obese patients more likely to get it than non-obese patients?
Not in particular. I think obesity in general predisposes you to a lot of health risks. And there is an increased association with cancer in general, but specifically colon cancer, no. Cancers are broad, across the board, essentially, are increased in obese patients, but it's not a focal, risk factor that I could say specifically, if you're obese, you're going to get colon cancer.
All right. Now, there's something called and I want you to explain what this is, a polyp. And you always hear about, I had a polyp removed. Exactly what is that, and how does that relate to cancers?
So a polyp, the best way to describe a polyp, and actually pictures are worth 1,000 words,
right.
But it's a growth of tissue that kind of grows up.
Grows into the bowel.
Grows into the bowel.
Bowel wall. All right.
And
okay.
As we were talking before, cancer starts essentially as abnormal growth of tissue. Polyp is actually the beginning of that sequence. So a polyp is a abnormal growth of tissue. That's essentially what a polyp is. Now, not to complicate it, there are different types of polyps. The type of polyps that grow into cancer or turn into cancer are adenomatous polyps. There are other types of polyps that don't have the same risk as adenomatous polyps. But when we're talking about cancer, it's adenomatous polyps.
Okay. Now, how we determine which is adenomatous and that's a fancy word. We're really throwing these big words out there. But that type of polyp would be a doctor would actually take it out, and we'll describe some of that later. And a doctor would have to actually look at it, right?
Right. This is
cut it up and look at it under the microscope.
Right. You can't just visually look at it on the outside and say this is an adenomatous polyp versus a juvenile polyp versus hypoplastic. You have to actually take it out and look at it under the microscope.
Okay. All right then. All righty. Now, when a person comes to you and sits in your office and they don't know they may not know they have cancer, what are some of the signs and symptoms or questions that you may ask them to try to figure out what's going on as far as their bowel is concerned? They may come for constipation or diarrhea or abdominal pain or whatever it is, and you have to, as a physician, try to figure out what's going on. How does it come together to you to, and what's the most common way a patient presents, maybe, I should say?
Well, the unexplained weight loss is a huge sign of cancer anywhere, actually. New changes in your bowel habits. So if you previously weren't constipated and now you're showing signs of constipation, abdominal pain, rectal bleeding. These are all signs that you potentially may have something going on in the colon or rectum. Unexplained fatigue. If you previously were energetic and now you're constantly tired, that may indicate that you're losing blood in the colon, which are all signs of presentation of colon cancer.
Interesting. And from there, what do you do? Do you test for blood in the stool, or do you send them to another doctor, or how do we get to? What do we do to figure this all out?
So I think, and we can talk a little bit about screening at this point.
Why don't we jump right into screening?
Okay. Well, screening itself is designed to pick up lesions or pick up cancer or pre-malignant lesions. To pick things up at a stage where...
All right. Pre-malignant. That means lesions before they become cancer.
Correct.
Gotcha.
Correct.
All right. So now I didn't want to break your thought. Go ahead.
So screening programs are designed to pick things up early.
Right.
Before they have the ability to cause serious problems. And the reason we want to do that is we know when we pick things up early, our treatment is more effective and the outcome is more effective.
Right.
So for colon cancer, our screening modality, really, there's fecal occult blood testing, which is testing the stool for blood.
Okay.
sigmoidoscopy and barometer and colonoscopy. For practical purposes, the one that we typically use and most practical is colonoscopy, which typically you start at age 50 and every 10 years unless there is something found. Now, patients who have a family history like we were talking about before, or who have predisposing factors to develop cancer will start earlier. So
earlier than 50 years.
Earlier than 50.
Right.
And really the colonoscopy is designed to pick up lesions like polyps that can be removed before they turn into cancer.
Okay, okay. We're going to step back a minute. You know that, right?
Sure.
Okay, you said several things, and I don't want to spend a lot of time on it, but sigmoidoscopy is, it's a little scope that they look from the rectum, just a portion of the rectum, right? They look in to see what's going on.
Right, and actually the majority of cancers are on the left side and down. So the sigmoidoscope should pick up the majority of cancers.
Okay.
Now, a full colonoscopy, we should go all the way from the anus, which is the very end of the GI tract, all the way to the beginning of the colon, which is the cecum.
Okay.
On the right side.
Okay.
A sigmoidoscope only goes to the beginning of the left colon.
Okay.
But again, the reason why it's part of the screening is because most cancers actually are going to occur in that region.
Okay, okay. Let's say that. We're going to explain this because, all right. So what we say is that if I was looking at you and I'm trying to figure out where we are in the bowel, we start in the rectum area. The scope actually comes up and it comes to it's on your left but my right, and it goes around and it comes up under the diaphragm, goes all the way around and then down again.
Right.
So when we do a colonoscopy, and this is a big scope, it goes in, up, around, and down.
Correct.
And looks at all of that bowel, and that's the colon.
Correct.
Excellent, excellent. Now, when you find this abnormal area in the colon, what are our options? What can we do about it? I mean, okay, so you're a doctor. You found that this person has an abnormal problem. Where do we go from there?
All right. Well, I'm going to step back one step further, just like you. So one of the common things, again, cancers that present with symptoms are usually advanced. So we want to catch them early on. One of the things that allows us to do that is screening. The other hallmark, which is very important, is any patient who has anemia, adult patient with anemia,
low blood count.
A low blood count,
right?
Especially males.
Okay.
You have to worry that there's an underlying cancer somewhere in the GI tract. That's the most common presentation. Okay. If you have unexplained anemia in an adult, male and female actually, you have to worry that there is an underlying malignancy, GI malignancy. Okay. So to get to your question, if we find something, a cancer somewhere in the colon, the next step really is to figure out what stage it is. And this is pretty common in cancer. We diagnose it, we stage it, and then we treat. Now, staging essentially means, is it just localized to one area? Okay. Has it spread to the lymph nodes, or has it gone to distant parts of the body? Because each stage is treated differently. So it's either localized, regional, or metastatic. Okay. All right. And based on each of the stages, the treatment will be different. Okay. So once we get the diagnosis, the next step really is to get something called a CAT scan. And a CAT scan is a special x-ray that we take of the body to look all throughout to see if the cancer has gone to other places. Okay. Based on that, we can get a stage, and then as long as the cancer is localized, the next step really is surgery.
Now, when you say localized, you mean it's in one spot. Usually it's in one spot. Correct. Or one general area.
Correct.
That you can either go in and take out, or we can give some other type of therapy to prevent it from growing or to kill it altogether, but it's in one spot.
Correct.
When you say metastasis, it means it's gone to another organ or outside the region of that little spot.
Correct.
All right. When you said another word, it said lymph nodes.
Right.
Could you explain lymph nodes? I know for me in pulmonology, I'm pulmonary, I always think about it as a patient with a sore throat.
That's right.
And you get these little knots under your throat, and once the sore throat's gone, the little bumps go, well, knots that you feel they go away.
Right.
And those are lymph nodes coming up. But you say they can be involved with cancer as well?
Right. So the lymphatic system, or the lymph nodes, which are a big part of the lymphatic system, are really there to filter the blood and filter the lymph, really to protect us from infection and to generate an immune response.
Okay.
It also filters cells and everything else coming from the body. So cancers actually that start in one area drain through the lymph node, and that's how that's one of the mechanisms of spread. Is cancers are drained to the regional lymph nodes and then potentially to other areas. So if you have an enlarged lymph node, it could either reflect a malignancy or a cancer, or it could reflect an infectious or inflammatory process.
Right. So there's two reasons why a lymph node may be enlarged.
Right.
Either cancer cells from somewhere else come up there and it's growing at that point or in that location, or it could reflect an infection because lymph nodes put out lymphocytes that help us fight our infections.
Correct.
Excellent. What about as far as prevention? What can we do to prevent colon cancer?
Screening is key. I think we're not at the point now where we can, at least not yet, sequence your genome or all the genes in your body and figure out who's going to get it. Right. So for most people, we don't know who's going to get it unless they have a family history. So really get an appropriate screening, which starts at age 50 if you're low risk, and just paying attention to signs and symptoms, really. Again, things like an appropriate diet, a high fiber diet helps, and basically that's mainly it.
That's mainly it. Now, what about as far as, now you had talked about surgery, and I know you're a surgical oncologist, so we haven't even gotten into surgery yet. That's what you do,
Right.
So tell me about this. I mean, this is obviously a specialty that you went to many years in training for, to be able to do surgery on cancer cells. And cancer cells are usually very delicate cells that you have to make sure that the surgery is done right. I understand. Just tell me a little bit about surgical aspect.
So the principles really of surgical oncology are to obtain what we call, and this is another big word, I'm sorry, local and regional control. So what the surgeon can control is the gross disease. Okay. So I can take out all the things that I can see. We know cancer spreads very early on, and it could have multiple areas that are microscopic that we can't see. But our job as surgical oncologists or cancer specialists in general is to take out the gross disease. Medical oncologists, which is another part of the group, treat the systemic disease, the things that we can't see, and they treat that with chemotherapy. Okay. The other specialists that we work with are radiation oncologists, and they give radiotherapy to help to decrease the chances of it coming back in the area that we did the surgery.
Okay, so radiation, you're actually giving radiation as a treatment, and that's
correct.
Zapping the cells, the bad cells, and killing them.
Correct.
Oh, all right. And chemotherapy is similar. Because the cancer cells reproduce so fast, the chemotherapy, it goes after those cells that are reproducing really fast and kills those. And it kind of leaves, hopefully it leaves the normal cells alone.
Right. And it really treats, it's designed to treat systemically, so all throughout the body, where surgery really is a focal area, a focused area. So.
Okay. All right. Well, we're going to have to end it there, and it's such an interesting topic. I mean, very, very interesting. We'll have to, come back and talk about many other aspects as far as colon and surgery and as far as cancer is concerned. But I'm so glad that you could come in and, just bestow the knowledge to all of us, because I learned a lot, too, from listening to you tonight.
It's great to be here.
Thank you very much.
No problem. Thanks.
Right now, I would like to come to my Let's Talk segment. And today I'd like to talk about congestive heart failure or heart failure. I had an email of someone that stated that their mother had heart failure, and exactly what is that? Basically what it's called, what's happening is that the heart is broken up into 4 chambers. And each chamber has to pump blood from the first chamber to the second chamber into the lungs, so that the lungs can allow the blood to get oxygen and all the oxygen rich at that point. And then we go to the 3rd chamber and then the 4th chamber where the blood is pumped out into the body. What happens with congestive heart failure is that one or two or all of these chambers become weak. And in trying to pump the blood from one chamber to another, the fluid part of the blood, or the watery part of the blood, backs up on the lungs. And you know, the lungs act like a sponge. If it comes in contact with a lot of fluid or a lot of water, it just soaks it up, and that's called congestion. That's why it's called congestive heart failure. When that congestion or that fluid comes into the lung and it acts like a sponge, and the sponge gets nice and soggy, it inhibits, or it decreases the ability of the oxygen in the blood to go across, or in the lung to go across into the bloodstream. This is congestive heart failure, and that's why the patient is short of breath. In ending, as usual, I want to talk about caring and sharing. Let's share our med moments. Email me. Let me know what's going on out there. I really love your emails. That way I can continue to do good things and put on the best, bring on the best specialists, I should say, for the show. Remember, never institute any change in your medical therapy until you see your physician. I trust each and every one of you continued good health. I'm Dr. Omar Bey, and this is A Moment in Medicine. Until next time, peace to you all. Excellent, excellent. You did very, very well, and I'm glad you came.